to Dr. Priya Pillai, thank you very much for the kind introduction. And to Dr. Hussain, I must say a big thank you for joining us today. You are a wealth of knowledge on this topic, and thank you for sharing your insights and thoughts on this topic. So without further ado, we shall begin. So a bit of background on the infection. Helicobacter pylori remains a major health problem worldwide, despite a number of years of research or decades of research. And it causes considerable mortality and morbidity due to peptic ulcer disease and gastric cancer. Atrophic gastritis, which is caused by persistent H. pylori infection, can lead to types of gastric cancer, to the point where the World Health Organization classifies H. pylori as a group 1 carcinogen, and it is up there with tobacco smoke and asbestos. So when we look at bacterial infection, we always look at the classic triad: environmental, host, and bacterial factors. And here we have to look at these three for bacterial infection, but also how does it influence progression to malignancy. Now, the burden of this disease falls disproportionately on less well-resourced populations, unfortunately, and in individuals of all ages. And estimates suggest that about half the world's population is affected. Serologic evidence of H. pylori really finds this disease in the younger age group, younger than age 10, but it does increase to about 10% in the 18 to 30 year category, and about 50% in those that are 60 years and older. Seropositivity rates in South Africa can range between 60 to 100% depending on the region. So the largest impact on reducing this burden comes from something that seems quite simple: improvement in socioeconomic status, which interrupts the transmission. And the last key statement, which is from the World Gastroenterology Organization Global Guidelines, says that the major determinant of the prevalence of infection is socioeconomic status in childhood. So the higher the prevalence, the lower the socioeconomic status. And I'll explain why childhood. So let's delve into the global and regional variants of this infection. So we'll find that between countries and even within countries, there's considerable variance in prevalence. And transmission, as we've said, is associated with socioeconomic conditions. As with most endemic infectious diseases, a fall in prevalence has more to do with improvements in population hygiene, water provision, and sanitation, rather than individual case-by-case treatment. As in most countries, only a minority of these infected patients will ever receive therapy. And the very same is for H. pylori, because it has to deal with availability of the drugs, diagnostics, cost factors. So you would rather focus on socioeconomic improvement to decrease prevalence. So optimal clinical management and treatment pathways remain unsettled. As we know, the treatment strategies involve a number of antibiotics, a number of drugs, and it involves good patient adherence, and even are those drugs even available? And the other problems are the antimicrobial resistance patterns that are ever changing that impacts which regimen to use. So like we said, there's been decades of research and clinical practice, but major challenges remain. And as with all diseases, the quest is for finding an effective, safe, and simple therapy, obviously for the patient, but also for the clinician to be able to treat well. And with this type of endemic disease, you would think an effective vaccine would be the answer, but the search for this appears to be elusive still. So what is H. pylori's story? What is the epidemiology? Where does it start? So looking at the natural history of infection, it persists for life unless it is properly treated. Or there have been cases of auto-eradication that have been reported. Reinfection with H. pylori following successful bacterial cure is unusual. And I think we must stress on the successful bacterial cure, because there are a number of factors that impact on this, like we said, availability of drugs, diagnostics, etc. Recurrence of the infection most commonly represents recrudescence of what was originally there, the original bacterial strain that was maybe inappropriately treated. Looking at the transmission of H. pylori, it is contracted during childhood. Humans are the primary reservoirs, and the route of infection is unknown, but it's thought to be person-to-person transmission, either via the fecal-oral and oral exposure. And here, caregivers and specifically mums are thought to be the people that actually transmit the infection to their infants. Iatrogenic infection has also been documented via inadequately disinfected gastric devices or endoscopes. So being a clinical microbiologist, and thankfully Dr. Hussain as well, we always like to talk about the weird and wonderful aspects of the microorganisms, and H. pylori is one of those weird and wonderfuls in terms of its spiral shape. It's microaerophilic, it's fastidious, and it's a gram-negative bacterium that chronically infects the human gastric epithelium. It has around 2 to 7 flagella, which allows it to have enhanced mobility, to move through the treacherous gastric solutions, fluids, and one of the important pathogenic factors or virulence factors is its production of urease. Urease is important for the organism's survival and colonization, but it's also important for us in terms of it forms the basis for several invasive and non-invasive tests to diagnose infection. So what are the other microbiological aspects of H. pylori? So as we said, for successful infection of H. pylori, it does need its host factors. And herein, we can look at factors such as, could it be age? Could it be smoking, alcohol that further potentiates H. pylori infection? Could it be your ethnic group, your gender? We spoke about the environmental conditions of the surroundings and the stomach. And then most importantly, the bacterial virulence factors. We spoke about the shape, having flagella, the motility, but there's also chemotaxis and adherence that render bacterial colonization in the gastric epithelium successful. Two very important pathogenic factors, which is cytotoxin-associated gene A, or CAG-A, and vacuolating cytotoxin A, VAC-A, are quite heavily studied, and they are closely involved in epithelial cell apoptosis and the development of severe gastric complications such as peptic ulcer disease and the gastric cancers, gastric mucosa-associated lymphoid tissue lymphoma, and these two have been focal points in studies. So looking at a picture of what happens with H. pylori after ingestion, it's ingested, it releases the urease, as we said, which is an important virulence factor. The urease breaks down urea into CO2 and ammonia. The CO2 is quite important for our diagnostics because it's detected via the urea breath test. The ammonia is a protector of the organism, which allows for creating a near neutral microenvironment for the organism to live in that gastric acid. And the organism then further moves into and damages the mucosal layer while secreting more bacterial proteins, which are also used for detection of the organism, detected in the stool via stool antigen tests. So with the further destruction of the mucous layer, the organism gets into the epithelial cell where there's an immune response generated inflammation, and further bacterial proteins are released, such as the CAG, such as VAC-A, and this now causes the further persistent infection, colonization, which then leads to carcinogenesis and apoptosis. So in a nutshell, H. pylori is able to stimulate a robust inflammatory and immune response, which perpetuates tissue injury. And collectively, with bacterial colonization and its virulence factors and the immune response, these are all important for the pathogenesis of H. pylori related disease. So what are the associated diseases? So let's look at initially the acute acquisition. So natural H. pylori acquisition may cause an acute upper GI illness with nausea, pain, vomiting, belching, and sometimes fever. It is very short-lived, sometimes only a period of less than 1 week. But what is noticed is that for many individuals, the acquisition of H. pylori is clinically silent. And in the weeks after the acquisition, an intense gastritis may develop with hypochlorhydria, and this may persist for as long as 1 year. So looking then at after the acute acquisition of H. pylori, the patient then becomes colonized with H. pylori, and then we spoke about the primary phenomenon of tissue response, where there's this immune inflammatory response. From there are several secondary phenomena that can occur, that can then lead to clinical outcomes. Secondary phenomena that is noted is atrophic gastritis, or changing of the gastric mucosa, and this has been thought to be linked to gastric adenocarcinomas, non-cardia. If there's a secondary phenomena of hyperacidity, this has been linked to duodenal ulceration. Secondary phenomena of antigenic stimulation has been linked to the MALT or the B-cell lymphomas. And then unusually, secondary phenomena that's not very well understood, but has to deal with the immune system. We have to then look at what H. pylori infection does to gastroesophageal reflux disease. And it's found to actually have, it decreases the risk of GORD and its complications such as Barrett's esophagus. At this point, I'm going to hand over to Dr. Hussain to continue the presentation.
Thank you very much, Mageshri. Thank you, Priya, for the introduction. And if I can remind everyone, although I think many of you remember the story, the discovery is a great one to go back to, because as you guys recall, it would be Barry Marshall and Robin Warren that discovered this organism's full scope of ability. And the way to prove it in the classic scientific methodology was to ingest it and then determine what would happen next. So they obviously anticipated this and could prove that this organism was not a passenger, but had the ability to be a pathogen, and were awarded the Nobel Prize for that discovery. It was 23 years ago since that discovery. And I think to Mageshri's point, this organism is very special. It's one of the organisms that have evolved together with humans. So one can date the evolution of the organism back to the humans' migration across the different parts of the world from Africa into Eurasia. And why this is significant is because unlike a classic pathogen that immediately can be recognized as a threat, Helicobacter is more subtle. Helicobacter at times will be just part of the microbiota of the gut, but as Mageshri alluded to, there may be environmental, genetic in the host factors, or genetic in the bacterial factors that change this dynamic. So the slide that Mageshri had shown earlier around the disease outcome of Helicobacter infection had the clinical outcomes listed as primary, secondary, and then the final outcomes. And there's also an association, therefore, of odds. What are the probabilities of these events occurring? Because Helicobacter varies not just in the prevalence across the countries, but also in the population, there are variations around the strains. We will find that these data points are not going to be reflective of every region in the world. And this has been shown through different studies, but I will list one recent one that was performed on isolates from Nigeria and South Africa. And in this study, the H. pylori was isolated from 220 biopsy samples, and different bacterial genotypes were identified. So it's not enough to talk about Africa or even South Africa, because we've seen from data sets that there may be potentially the same strain, and I'm referring here to the organism, but we haven't got enough data to show that level of detail. But I would not be surprised that we have different strains even in South Africa. But here clearly you can see that there are different strains between Nigeria and South Africa. And this was confirmed in the sense that there was an endoscopy finding showing that Nigerian patients had significantly more erosions. So where I'm going to with this is on my next slide, where we speak about the African enigma. And the African enigma refers to the fact that sub-Saharan Africa has a high prevalence of Helicobacter pylori, but a low incidence of some of its outcomes when one considers the prevalence. And GC here, I'm referring to gastric cancer and of course duodenal ulcerations. But I just showed you in the previous slide that the word or the continent Africa, we are oversimplifying. And the African enigma is not a new concept or challenge, but this has emerged over time as more understanding and data since Prof. Marshall and his colleague Robin Warren discovered the impact of the organism. The next question would be, if the organism is so prevalent, you saw that the data can range between 60% to even 80%. In the case of Nigeria, it's close to 80% as far as I recall from some of those serological studies. Where then is the gastric cancer cases in relation to that? Where in Asia, we see very high rates of gastric cancers. So some of the theories around why there are different data sets around gastric cancer and the outcome of H. pylori infection in sub-Saharan Africa could be perhaps that the population life expectancy is shorter in those African populations. Perhaps the issue is more linked to the fact that there's poor access to healthcare resources. So confirmation of the clinical outcomes has been less well documented. Perhaps documentation itself is not very robust. Then there are other factors that influence Helicobacter's outcome, and these are immunological factors. Hence, helminth infection. So infection with a parasitic organism that doesn't necessarily get resolved very quickly actually shifts the patient's immunological response to a T helper 2 response, and it sort of ameliorates the inflammatory reactions that are needed to drive multiple processes that can be associated with gastric cancer and duodenal ulceration linked to Helicobacter. In the pathophysiology slides, you'll recall that Mageshri was showing it was an immunological response that Helicobacter was inducing that leads to these changes. But we cannot be complacent, and therefore, could it be that we will see the incidence of gastric cancer change in Africa? So to consider these diagnostic strategies is very important for Africa specifically. The consequences of colonization differ regionally, but also globally. What makes it even more challenging, because there are different consequences, there are different algorithms for testing and treating Helicobacter infections in different parts of the world. What we were missing was an African perspective. The African Helicobacter and Microbiota Study Group was founded in 2022 with the aim of creating consensus on testing indications, diagnosis, and treatment in Africa. Aside from this, the group is also going to be focused on trying to drive projects, much needed surveillance projects on Helicobacter, so that we can understand the African Helicobacter challenge in more detail. And then just to go back to what I'd alluded to in that previous slide, what are the diagnostic modalities? So diagnostic modalities in Helicobacter can be summarized as being either invasive or non-invasive. While on this slide, I will just highlight the invasive slide, the invasive tests, because I think it's important to note that there are different implications on even molecular testing. So molecular testing could either be, is Helicobacter at the top level, is Helicobacter present or not? That can be a molecular test. One can go a layer below that to NGS, which is next generation sequencing, and next generation sequencing can give one a lot of detail. So it is possible with next generation sequencing to identify the resistance profiles of multiple different antibiotics. But next generation sequencing is very expensive and is not freely available. So why I highlight this is because there may be this hope that we will be able, using molecular, to solve all of our riddles around Helicobacter and other organisms. But one must distinguish NGS, which is next generation sequencing, from routine PCR, which is our polymerase chain reactions that are routinely available in laboratories around the world, especially now that we've had the COVID experience, where there are labs even around Africa that now have got some machinery that are able, some lab platforms that are able to distinguish before I forget going forward. So let's just look at this in a bit more detail. So the gold standard for Helicobacter confirmation and detection is histopathology. Histopathology relies on endoscopy. Endoscopy is to a degree to obtain endoscopy services. That being said, it is still the gold standard. What is important the rapid at that time. Rapid urease has its own caveats. Rapid urease is sensitive results from rapid urease. Culture, the culture is a challenge. Culture is Helicobacter in the first place. As Mageshri alluded to, being a microbiologist, we enjoy in the course of our study, when she mentioned the organism is microaerophilic, it means for us in the laboratory, this is a very difficult organism to grow. You require an organism you require media that is well suited to the organism, and the organism needs to be transported as quickly as possible from the theater to the microbiology lab in saline. So the importance is to obviously separate the formalin from the saline. One has to separate that. Otherwise, when you send the formalin samples, one cannot do the culture. So that's one important aspect to remember. You'll see that the recovery rate is varied. It varies between 24 and 85%. That's because of all of those different factors that can influence it. Do you have special transport media? Is the lab ready for the sample? So if you wish to send in a culture, one of the best ways to do it is to just warn the lab and say you want to send a culture sample in, so that the lab is geared up and ready to try and assist you as best they can to ensure that the culture is successful. The benefit of culture compared to PCR is that with culture, I mentioned that there are more than just the classic antibiotics that one can test for on PCR. Sure, there's next generation sequencing that one can look at all those other antibiotics, but that is not readily available. So culture comes into play when the routine antibiotics are not enough. And the routine ones are available on PCR, but culture is when you need the additional ones. In the non-invasive tests, I'll highlight the urease breath test. This is also seen as one of the gold standards. And the non-invasive tests, when the validation studies and comparisons are done, they will always use urease breath test as the comparator. Urease breath tests are highly sensitive and specific. They also imply, importantly, active infection. I'll contrast that to serology. Serology implies there's an immunological response, but it cannot distinguish active from previous infection. Serology's purpose is more for population studies and evaluating what the epidemiology is of Helicobacter in the population, general population is. In ANPATH, we have a very large amount of specimens that still come through. There are serology samples, blood samples. And the challenge with this is that the clinicians are potentially using the serology to make the decision to treat. And the danger, of course, is that this could be a previous infection. You cannot prove eradication with it. So you don't actually know where you stand with it. Stool antigen is the preferred test, and I'll show you in more detail why. But on a practical note, patients don't like bringing stool, and patients don't like submitting these samples because of a variety of reasons. Collection, embarrassment. It's a problem. I acknowledge this, but I really urge you to switch from serology to stool as your preferred non-invasive testing method. Just to pause a little bit on stool antigen. Stool antigens are either monoclonal or polyclonal. So when you read statistics that are very big bucket statistics, like as you've seen here with sensitivity and specificity, they are detailed. And I mention this because there may be a perception from you having had an experience with a stool antigen test that didn't result in what you had hoped for. I would urge you to interact with the laboratory and engage to understand whether or why the result was different. There are laboratory factors that come into play. And if you wish to learn more about that, the best way to do that is to discuss this with the lab. We choose the best option, which is the polyclonals, and we have ongoing validations to make sure that they are the best for your diagnostic purposes. So when do you test becomes the next difficult question. I'd mentioned you have to consider where in the world you are. So in China, Korea, parts of Asia where they've got a high prevalence of gastric cancer, there are large screening programs that are linked to endoscopy. In our environment, this is not necessary and not advised, but it's just to give you a feeling of how different this problem is in different parts of the world. So our testing indications are more in line with the fact that was there current or past peptic ulcer disease, gastric atrophy, first-degree relatives of patients with gastric cancer or multiple lymphoma, then functional dyspepsia, and then interestingly or importantly, prior to the administration of long-term NSAIDs, where there are studies to show that the outcomes linked to ulceration will be less if you get rid of the Helicobacter before you start the NSAIDs. And then in unexplained iron deficiency anemias and unexplained thrombotic purpura, thrombocytopenic purpura. Just going a step back, because on invasive testing, what I think I should have been highlighting as well is who are the patients that require those invasive tests. There are a subgroup of patients that you cannot do a non-invasive on. There are patients with alarm symptoms that you think have where peptic ulcer disease has led to life-threatening, potentially life-threatening conditions. Situations, and then you do have to obviously go for endoscopy urgently, and then in patients older than 45 years with dyspepsia, endoscopy is preferred. When one is looking for Helicobacter in biopsy samples, the more the samples, the higher the chance of finding the Helicobacter. This is an issue with regards to what are the odds that you find the organism present. Sometimes you'll obviously see the cellular changes linked to atrophy, and then it's one thing, but where it's difficult to see the organism, there are special stains, but they are expensive. So immunohistochemical stains are available, but in general, preferred not to use because of the cost. on the biopsy sample, I had highlighted that we can, on the biopsy sample, perform genotypic tests. That's the PCR. It will tell you, is Helicobacter present, yes or no? And then secondly, is there clarithromycin resistance or levofloxacin resistance, yes or no? Those are the two antibiotics where genotypic testing is most well validated. Phenotypic just refers to culture, and I'd highlighted there for both genotypic and phenotypic, it's preferred to use the saline sample. That being said, if it's in formalin, we might have a chance with using genotypic, but phenotypic, it is not going to happen. So the Africa Helicobacter microbiota study group has made a statement that I think is a big one. And consider, in light of my points around the Africa enigma, the AHMSG has decided that H. pylori should be eradicated if detected because of the prevalence. I mentioned 60 to even 80% prevalence. If you were to do a test on a patient, you'd have a high rate of finding a positive. So in the opening slides, Mageshri had highlighted that because it's a type 1 carcinogen, WHO has advised it should be eradicated. What has been difficult to get over has been the challenge of the African enigma. In other words, if it is present, should you eradicate it? Because we know that it is present in so many people, but doesn't lead to the same amount of gastric cancer and peptic ulcer disease. Eradication is not simple in Africa. It's costly, and it might not be easy because you don't have access to antimicrobials. So I do think this is a big statement and a stance to take, but I do agree with it, obviously. I think it makes a lot of sense to take this road, but I'm sure it will be a topic of debate, especially considering, you'll see I'm not mentioning some of the assays that are out there and available that will give you more indication of whether a patient has got an atrophic gastritis or not. In other words, pepsinogen and gastrin. So that is something we can talk about in this webinar if you would like. But the term for the strategy that Sub-Saharan Africa is following is a test and treat strategy. It's a non-invasive testing method, a non-invasive strategy, unlike, as I mentioned, say Korea and China, etc., where they might want the invasive screening approach. We are not following that unless there are alarm symptoms. The stool antigen test is the preferred non-invasive test due to that limitation on the access to urease breath tests that all of us experience, including the laboratories. Urease breath test is complicated in the sense that there are different cutoffs as well. It's not as easy as what it seems. We have moved away from the radioisotope that is linked to potential malignancy complications. That's the 14 carbon. In general labs are using 13 carbon UBT, but it is still challenging because of the cutoff range I mentioned. Interestingly, those cutoff ranges can vary with unusual, unexpected patient demographics. So you'll find different cutoffs in females versus males, obese versus non-obese. It is factored into the sign-outs, but it is complicated. So the diagnostic pathway that the Africa Microbiota Study Group is following is simple. If the patient requires, for invasive at least, start off there. Does the patient need an invasive test? Yes or no? And that's based on, as I mentioned, those alarm symptoms or that edge with dyspepsia. If the patient has gone for the invasive test, is the patient on a PPI or is on antibiotics or bleeding? That will just make the rapid urease test less valuable, and then histology becomes more important. Considering cost implications, that's why there's that variation there. You can choose not to send for histology if you get a rapid urease that's positive and you know what you should be treating based on the patient's history. You can avoid cost, but of course there's a risk with that. So understanding that is important, but I'm pointing it out. On the non-invasive side, is the patient on PPI or antibiotics? If the patient is, you need to stop the PPI 1 to 2 weeks before you do your next stool antigen or urease breath test. So this is where the slides get even busier than before. Helicobacter treatment. It's important to add I think the gastroenterologists know this very well. Me being a microbiologist, I was not conscious of this important fact. the PPI is critical. PPI, the proton pump inhibitor, is the gateway to success with Helicobacter. Without the PPI, the triple therapy is not going to be worth its weight in salt. So PPIs enable the antibiotics to work. What makes that really complicated in a laboratory setting, I cannot in the laboratory measure the impact of a PPI. That is the reason, in my opinion, we have this difficulty in pegging down the best treatment algorithm, and why you might find patients having varied responses depending on duration. But there are certain things that have become completely accepted. The duration of treatment being one of them. It started a few years ago with maybe 7 days. We've moved to 14 days. By and large, you'll see some of the documents will vary 10 to 14, but by and large, it's 14 days. It's accepted that the standard triple therapy with clarithromycin, amoxicillin, and PPI is will achieve the best eradication rates. But it is completely dependent, triple therapy, on clarithromycin's sensitivity at the time of treatment, and whether the patient has had a previous clarithromycin course. But using that, keep that in mind, keep triple therapy as your golden way forward, because everything depends on, is triple therapy appropriate or not? If triple therapy isn't appropriate, then you can make your subsequent decisions. So I just want to highlight some options that are not available, but it's worth knowing about them. And bismuth quadruple therapy is what I'm referring to. So bismuth is not available in SA freely. You have to get it through a Section 21. Tetracycline is not available freely, and substituting with doxycycline is not advisable. I've not seen much data on substitution, and I would steer away from it. I've come across a few scenarios where it has been put into patient algorithms, but I'm hesitant to advise it. The data is linked to tetracycline. Bismuth quadruple therapy is important because it has become first-line treatment in certain areas where the clarithromycin resistance rates have become too high. So quadruple therapy with bismuth has become a very important backbone. But we in SA do not have access to it. Concomitant therapy is an interesting one. It's amoxil, clarithromycin, metronidazole, and the PPI. I say it's an interesting one because in South Africa, I've noted varying utilization rates of the concomitant therapy. I think mostly due to cost and concern that it isn't going to have an impact. Why I'm interested in it is because you'll see in this particular block that there was a randomized control trial a while ago that was speaking that showed its value compared to triple therapy. But the European guidelines have also noted that one might be using concomitant when you don't have access to the bismuth quadruple. But this is a lot of, these data sets are not big around what I've just mentioned. The other point is you'll notice this term eradication rate is used a lot in what I am saying. We have very limited data on African eradication rates and even less on South African eradication rates. So just keep that in mind. Levofloxacin regimens have become a very important regimen in South Africa, and I'm sure many of you have been using them. So with that busy slide, I'll show you the next busy slide. And I hope then to not, oh wait, there's one before we get to the very busy one. And that's what data have we got around clarithromycin resistance? Just to give you a feeling, we shouldn't be using it empirically, where regional resistance is above 15%. We don't really have validated regional surveillance data on resistance. We are going to develop it. We are on that road, but in the meantime, we are using surrogate data. So you'll see WHO, this is from World Gastroenterology Organization's dataset where they quoted Africa region overall. And in the study I had mentioned earlier, South Africa versus Nigeria, they did do both culture as well as molecular studies, and you'll see the clarithromycin resistance in SA is above 15%, close to 20%. In Nigeria, it's above 20%. That's just a contextual way of thinking. I was involved with a small study between Chris Ani Baragwanath and a private hospital comparing clarithromycin resistance, but these are in patients that are visiting gastroenterology clinics. So chances are they've been on clarithromycin before. that being said, in the Barra cohort, the resistance, if I can recall correctly, was around 12%. And then in the private sector was, in that cohort, was above 70%. But very big difference in what these patients have access to, etc. It's just anecdotal, but just to show you that even in South Africa, you will get different responses. So I tried to summarize a little bit of what is in the AHMSG recommendations, and then bring in a little bit of what is global, because the African data, the African recommendations are very open-ended. They make the statement, which we all can agree with, that where appropriate, use triple therapy as your first line. The problem, though, is that your success determinant is clarithromycin resistance, primary CR. What do you do when that is present? What are your options? I'm highlighting that you can consider concomitant therapy. There is a warning mark around metronidazole resistance, and in the AHMSG document, a lot of emphasis is placed on trying to avoid metronidazole, because in Africa, metronidazole resistance is documented as being very high, also above 70%. But the local data in South Africa is quite scarce, and metronidazole, when combined with a PPI, might still be effective. So concomitant therapy, I wouldn't be writing off too quickly. And I'll show you why I say that. What is interesting is that what I would avoid is the amoxil metro combo as a first line, because that is limited. So I would avoid that. The use of the levo as a first line is effective when you know what levofloxacin resistance is, and if you do use a molecular method early, you may already find the levo resistance or susceptible data very quickly. So that now does become an option if you have that. So if you start at the top with me, Helicobacter pylori, question number 1, does the patient have a penicillin allergy? If the patient does, then you'd have to move across to the bismuth combo, which is the PBMT, so bismuth metronidazole tetra, but that we have underlined in the red in this algorithm for us is not available. So what then? So I'll stay on the penicillin allergy. There the recommendation is go to metronidazole and clarithromycin if low resistance. Again, I'd highlight that challenge, and you might end up at salvage therapy for pen allergy patient. That is not ideal, because salvage therapy is based a lot on amoxil. So penicillin allergy is a massive problem, and those would be the patients I would straight off say you should try getting the section 21 document to get the bismuth over for. So that's one separate comment. Going back to the macrolide, again, I say macrolide exposure, you'll see in America, Europe, they go straight to bismuth. We don't have that. So then I would jump to my next level of options, and you'll see I highlighted it there, possibly to consider concomitant therapy with a previous macrolide exposed patient. What I'm referring to here, you'll see, is if we don't go there, the only line we have left, and that's where I've highlighted in orange, is the levo regimen. So if you are using levo, you've actually exhausted all the options above levo, if that kind of makes sense. And I say this because the other options you have, you'll see in the bottom in the little blue arrows, are rifabutin. So you can get rifabutin combos, and it comes in a single tablet at the moment. Eradication rates of that tablet are with the rifabutin combination therapies are around 72%. It's not great. So even if you get the rifabutin combo therapy, which is not available in SA either, you're still sitting with an eradication probability of 72%, which is not great. So I hope that gives a feeling on what the options look like. And again, I would say if you are on levofloxacin, it's not wrong. I'm just saying understand how far down the line you are. That's the problem we have in South Africa. So awareness that there are salvage regimens is important. This comes from American College of Gastroenterology. The American Gastro Organization has a different regimen slightly, but the bottom line is you should be upping the PPI as well as the amoxicillin dose. So you're giving high dose dual therapy. This can be effective as a salvage regimen. There are other very complicated regimens called the sequential therapy. I didn't even bring this in. Some of them are in second line guidelines. So I mentioned in the previous slide, when you're sitting at levo, you don't have options. Sure, concomitant, you can try out sequential. Sequential is essentially a longer version of concomitant. So you give the PPI, you give clarithromycin for a duration of 7 days, if I recall, and then you drop the clarithrol and you bring the other two agents on board. So it's more or less something like that. I'm not seeing enough evidence to show sequential is so dominant that we should be really focusing on it. It's also quite complicated for the patient. So if the patient compliance, we haven't even mentioned that, but I can imagine you guys who are in the front line actually seeing the patient can tell me a lot about the challenge of patient compliance in this situation. I've got the last few slides to highlight. According to the AHSMG, when should susceptibility be requested? So I've mentioned a couple of times about susceptibility being either genotypic or culture, which is phenotypic. According to the guidelines we have coming out, we should be looking at multiple failures of treatment courses, 3 or more failures before requesting for AST, which is antimicrobial susceptibility testing. So it's not culture. Don't think it's just culture. It's testing for antimicrobials. This recommendation is just that, a recommendation. So you will have to consider when you want to ask for it sooner. So patients that have got, it all depends on the history. So you need to check, has clarithromycin resistance entered the potential scenario? If so, request it sooner. You have to consider the cost and the value add. You should choose between doing the molecular or the culture. You can only do the culture on a biopsy. So then we're talking endoscopy. What is important and very valuable is advances in the molecular that have led to non-invasive susceptibility testing. That is stool. Again, unfortunately, patient will have to bring stool. This PCR can be performed directly on the stool, and clarithromycin and levofloxacin can be tested for. I personally am a bit unhappy with the false positives that appear on levofloxacin on the stool, on the PCRs that are currently available. But when one has to deal with these things, then that does become an option. So just to remind you, I mentioned that on molecular, you're going to be able to access clarithromycin and levofloxacin. The benefit is that it overcomes those traditional barriers on culture-based methodologies where you've got a recovery rate of 24 to 85%. In most labs, you'll sit with under 50%. I can say in our lab, it unfortunately is under 50%. So you need a specialized unit that focuses on this. Metronidazole resistance, a lot of questions come around our lab around, can we do that? I mentioned you can use next generation sequencing and sequence out the full genome, look for those known resistance markers and genetic resistance markers on the next gen sequencing. What has not been made clear is whether those actually lead to resistance. So metronidazole resistance on genotypic testing is very dicey. You always want to correlate with pheno, and by that stage you're asking, what does it really mean? So if you've got a biopsy and it's an invasive scenario, request for antimicrobial susceptibility testing is my advice. You've already done the endoscopy. My recommendation would be to request a molecular test as well as a culture for complex cases. If you don't have a complex case, it wouldn't be wrong to only request for molecular if you are assuming that the patient is a clarithromycin or levoflox sensitive patient. So you can save some cost. In our data sets, again, these are unselected patients. Clarithromycin resistance is around 33% in the total data set. We don't know the history of these patients. It's just worth noting. What we're missing, as I said earlier, is a real regional surveillance unit. Not to be forgotten is that once you've gone down that road, proof of eradication should be performed. I mentioned way back in the earlier slides, Africa, we are desperately short of eradication data. So we should be, as clinicians, trying to perform eradication in all patients 4 weeks after completion of treatment. The stool antigen test, going back to the stool, is one that is preferred. You can, of course, use the others, but they are expensive. There is a hope on the horizon when it comes to how are we going to tackle resistance in Helicobacter. I mentioned the importance of the proton pump inhibitor. We haven't seen a change in the antimicrobials. In other words, no new antimicrobial can tackle this bug. What we are seeing, though, is a potassium competitive acid blocker. And this new class of acid inhibitor has a much more potent and durable effect on acid suppression than the standard PPIs. Vonoprazan-based triple therapy with clarithrol and amoxicillin is the first line as ranked first in eradication meta-analyses so far. So we do think that this is going to be something of a game changer. We just don't yet have it, although I have heard that Adcock is looking at potentially bringing it into the country. I would still be worried about the cost and the access. I still believe we should be doing more to bring bismuth in. That's something that the gastro societies and other clinicians should be lobbying for. So just in summary, Helicobacter is a major pathogen and the prevalence of infection remains very high in many of our regions. Refining the diagnostic modalities has to continually be chased, and we do see some of that happening. I didn't talk too much on the other benefits and the point of care ways of thinking with UBT and even improvements in stool antigen testing. But optimal clinical management and treatment pathways in these different settings are a matter of debate. They're not straightforward, it's quite complicated. The quest for the most effective, safe, and simple therapy remains a major issue, and antimicrobial resistance is posing a major challenge to achieving what we all hope. Thank you so much for your attention.